Friends, welcome back to the show Talk with Your Doc, and with us is Dr. Graeme Marchuk, who's a neurosurgeon at Thunder Bay Regional Health Science Center, and we are talking about different causes of brain tumor. And in the break we were talking about cell phone use, and there is a warning when we buy a cell phone that keep the phone away from your from your ear, or keep the phone on the speaker mode or with the earphones plugged in. Is that a word of caution for the patients or our viewers to take home?
I mean, I don't. There's no definitive data that there's a direct correlation between the cell phone use that we do day to day and the development of something like a malignant brain tumor in the future. That being said, as we were saying, my wife likes to shut all that stuff off in the evening time, and I'm the one with the cell phone on as the on-call physician, waiting for it to ring in the middle of the night. So I guess over the years we'll be our own control study. So yes. if I get the tumor, then we'll know. But I don't think that people should be particularly worried about cell phone use.
How about dental radiations? You were mentioning that they can lead to.
Yeah, and again, nothing definitive, but it has come up in discussion in the literature about the potential deleterious effects of X-rays. And we're aware of this in medicine all of the time. We're careful with how much radiation we prescribe to patients and how many X-rays we order, CT scans. If I can, in the follow-up of somebody for a condition they have in the nervous system, I'll try to do an MRI as opposed to a CT scan because there's no radiation involved. Right. And so we're aware of these things. But in terms of a direct causal link, that data isn't present.
Right.
Yeah.
Now, once somebody has a brain tumor, either benign or malignant, how do the patient come to know? What are the signs and symptoms?
Yeah, so they can be variable. It's what fascinated me about neurosurgery initially was just the number of ways that people could present with this type of problem. And again, it depends on the age. And so if we're talking about the young children with the tumors that I talked about in the back part of the brain, that often presents as a child's just not right, headache, nausea, vomiting, those sorts of things, lack of eating, lethargy, those types of things that can develop. In the adult, the more typical presentation could be just a new onset headache. Now, headaches are unfortunately really common, and so just because you have a headache doesn't mean you should leap to the diagnosis that you have a brain tumor. But if there's some different character to the headache, or a headache that's escalating, that's clearly different or associated with other symptoms like nausea and vomiting, then that should probably be assessed. People can develop neurological symptoms as a result of a tumor. For example, they could develop a new onset weakness or numbness of the face or the arm or the leg. And that's unlikely to be an abrupt onset. That would make somebody think more of a stroke occurring. This tends to be more of a gradual decline. And so that's a fairly common presentation. And then seizure, a new onset seizure. Yes. And again, seizures are relatively common in our population. Most people that have seizures aren't found to have a brain tumor, but it is a common first presentation.
So the symptoms can vary from no symptom to the seizure or loss of cognitive abilities.
That's right.
Any of those symptoms we should approach a family doctor and get investigated properly.
Yeah.
Now, what sort of investigations are done to confirm the diagnosis?
Yeah, so you would see a physician. They would do a history of your complaint and examine you. Certainly if they find neurological symptoms like a weakness in one arm, or you're having clear trouble with the vision out of one side, something off with your speech, that would trigger some worry. Usually the first investigation would be an uninfused or a plain CAT scan of the brain. It's an easy test to get. You can get it quickly, doesn't involve any dye. It's a relatively low dose of radiation. And if that shows an abnormality, that may then lead to a dye study with CT, but then probably eventually an MRI scan of the brain.
So what is the difference between CT scan and MRI?
A CT scan, as I often explain to my patients, is like a circular X-ray. You lie in the scanner and the X-ray machine does like a circular picture of the brain and kind of divides that into slices. So it'll do about 45 or 50 slices, almost like we're slicing you like a loaf of bread, but it's radiation. The radiation beams bounce off of things that are dense like the bone, pass through tissues that are not dense like water, and everything else kind of shows up as gray. So it's a you end up with a picture that's contrast between gray and white and dark. And so it's good at showing fairly large abnormalities, not so great at subtle abnormalities.
Right.
And so an MRI scan is different. It's a magnetic field. We're actually imaging spinning protons in your body. It's amazing. And that allows us to acquire better tissue contrast. And so we're able to get much greater anatomical detail.
Right.
We can image in different planes. There's no radiation involved.
Right.
And so we're able to localize the pathology better and see some things that we aren't able to see on a CT
So
scan.
MRI is much more specific and gives us more detail about the diagnosis, while CT scan is a preliminary investigation.
Correct.
If that is abnormal, then we go to the next step as
Yes.
MRI. Now, once MRI shows a lesion, then you do the biopsy.
Yeah, so it depends on what it shows. There are some circumstances in which there are circumstances when we might just suggest an observational course if we
Okay.
think that it's a benign lesion, or we're maybe a little bit uncertain about what the MRI is telling us. Did this person maybe have a stroke in the past that they weren't aware of, and that we're just seeing the resolution of that? Sometimes it can be a little difficult to tell.
Right.
And so we may initially suggest a course of short follow-up. We'll do another image in a couple of months,
Right.
reassess at that time. If there's a large mass and the mass is causing a pressure effect on the brain, clearly causing symptoms, we could biopsy it, but often we'll just take that mass out as part of the treatment, and then we get the pathological diagnosis at the same time. We usually reserve a biopsy for something that's more deeply located in the brain, that we're worried that if we try to take it out, we might cause harm.
Right. So observation or surgical removal then. And that removal is also diagnostic as well as the therapeutic program.
Correct.
Right.
Yeah.
Now, do all the benign tumors need to be removed, or some of them can be left?
Yeah, so a lot of them we'll watch. A common tumor that we'll watch is something called a meningioma. So that's the meninges are the lining of the brain, and so that's a growth that arises from the lining of the brain. They're common as we get older, and even in younger individuals in 30s and 40s, we see from time to time somebody come in with a fairly sizable meningioma. These they're benign. They're almost exclusively benign tumors, but they can get large and start to push on the brain tissue. But if they're not particularly large, they tend to be slow growing on the rate of 1 millimeter or 2 a year, and sometimes they don't even grow that fast. And so if they're not causing symptoms, we may just suggest that that's observed.
So it is not necessary that all the tumors has to be removed. Some of them can be left for observation,
Definitely.
while some will be required immediate surgery.
Definitely those that have more of a pressure effect on the brain or are causing some sort of concerning symptoms, or we really feel like we need to know what the diagnosis is.
Yes, yes. Thank you, Dr. Marchuk. We'll take a short break and we'll come back for the next part. Please stay back for the next part. Thank you.